So I'm going to present an interesting study, an observational study on balloon mitral valvotomy in patients with symptomatic severe mitral stenosis with associated significant aortic valve disease and its outcome. Balloon mitral valvotomy has been established as an alternative to surgical mitral commissurotomy in the treatment of patients with symptomatic mitral stenosis for a very long time. Rheumatic mitral stenosis is often associated with significant aortic valve disease. Most of the symptomatic patients of rheumatic valvular disease involving both mitral and aortic valve undergo double valve replacement using mechanical heart valves. But valve replacement surgery itself has a high risk of intraoperative and postoperative complications, including the lifelong requirement of anticoagulation and its associated complications. Presence of mitral stenosis in cases of aortic valve disease can affect the clinical presentation. Aortic valve disease has a long asymptomatic course before it manifests with clinical symptoms. So presence of severe mitral stenosis per se can be the sole reason for a patient's symptoms in a case of associated aortic valve disease. In this background, hypothesis of our study was, in cases of severe symptomatic mitral stenosis and associated significant aortic valve disease, BMV instead of DVR can be the first treatment option. Symptoms of these patients can be reassessed after BMV, and if they become asymptomatic after the first treatment, that is BMV, we can defer the valve replacement surgery for the time being, maybe for a few months or maybe a few years. So aims and objectives of our study was to evaluate safety, efficacy, and clinical outcome of balloon mitral valvotomy in patients with symptomatic severe mitral stenosis and associated significant aortic valve disease in the form of either moderate or severe aortic stenosis or aortic regurgitation or in combination. Inclusion criteria was symptomatic severe mitral stenosis where the MVOA was less than 1.5 centimeter square or the MV mean gradient was more than 10 millimeter of mercury with either moderate AS or severe AS or moderate AR or severe AR or AS or AR in varying combination. Exclusion criteria was mild to moderate MS, mild AS or AR or both, mitral regurgitation of more than grade 2, left atrial clot of more than class 2A Menjoneth classification, bicommissural calcification of mitral valve, significant organic tricuspid valve disease or pulmonary valve disease, and in fast follow-up and second follow-up, whoever underwent valve replacement surgery was excluded from calculation of the result. So this retrospective observational study was conducted between February 2012 and November 2018. 49 patients with symptomatic severe mitral stenosis were associated with significant aortic valve disease who underwent BMV were included and were followed up clinically. MVOA by planimetry transmitral gradient and PSP by TRZ method were obtained. Aortic valve was evaluated for AV mean gradient peak velocity and AV orifice area to quantify aortic stenosis. 2D echo and Doppler parameters were used to quantify AR using jet width, vena contractor, pressure half time and other parameters. Pre and post procedure echocardiographic and catheterization data were recorded including MVOA, MV gradient, PSP, MR and commissural split. Aortic valve lesions were also assessed just after BMV in each case. Procedural success was defined as increased MVOA by 50% from the basal or a final valve area of at least 1.5 centimeter square in the absence of more than grade 2 MR. Restenosis was defined as loss of more than 50% of the initial gain in the MV orifice area. Patients were followed up after discharge and were assessed for the NYHA classification, severity of the valvular heart disease echocardiographically, incidences of rehospitalization, valve replacement surgery and death. Coming to the results, so this is showing the baseline characteristics of our study. The total number of patients were 49 with male and female ratio was like that, 19 were female, male and 30 were female. Most of them were in NYHA class 2, some of them were in NYHA class 3 and there were few Wilkinson's score less than 8 were in 26 patients, 23 it was more than 8 but all cases it was less than 12. The involvement of the aortic valve disease was like that, moderate AS 6.1%, severe AS 6.1%, moderate AR 22.4%, severe AR 4.1%, moderate AS with moderate AR with 22.4%, moderate AS with severe AR 2%, severe AS with moderate AR in 32.6% in maximum occurrence, and severe AS with severe AR in 4.1%. 40 out of 49 patients were in sinus rhythm, 9 had atrial fibrillation, 46 didn't have any LA clot, 2 patients had a class 1A and 1 patient had class 1B LA clot, and 3 patients had a history of prior BMV. So this is table 2 showing the pre and post BMV variables, and it is showing that the mean value of PSP, MVO and MVG mean had significantly decreased after procedure, showing with a significant p value, showing most of the procedures are successful. Now coming to the patient outcome data just post BMV and is equal to 49. 4 out of 49 procedures were successful, 5 procedures were unsuccessful, 2 had suboptimal result and the patient underwent elective DVR in the same hospitalization. 1 patient developed moderate MR and patient was treated medically. 2 patients developed severe MR and acute pulmonary edema and emergency DVR was done and patient survived. So 46 patients did not have any complication. 1 patient had moderate MR, 2 patients had severe MR. So just after the procedure in the same hospitalization, out of 49 patients, 45 did not require any surgery, 2 required emergency DVR and 2 required elective DVR. Now coming to the fast follow-up data in January 2019 with a mean duration of 35 plus minus 23 months, here n is equal to 45. The distribution of the valve involvement was like this. So out of 45 patients, 5 patients require AVR, 1 patient required redo BMP because of stenosis, clinical stenosis, and 39 patients, that is 86%, did not require any surgery. And the hospitalization was 5 patients due to elective AVR, 1 patient because of redo BMP, and 1 patient developed pulmonary edema and was treated conservatively, and there was no death reported in this study population. Coming to the second follow-up data, this was the distribution of valve replacement, but unfortunately there was good number of loss of follow-up. So here we could take data from 22 patients. Out of 22 patients, 20 patients did not require any surgery, 2 patients underwent DVR, and 1 patient expired because of a non-cardiac death. And the mean duration of this follow-up was 60 plus minus 21 months, and it was done in September 2020. So this is the result in summary. 49 patients, 45 no surgery, then fast follow-up, 39 no surgery, second follow-up in September 2020. Out of 22, 20 patients did not require any surgery. So the procedural success was achieved in 89.8% cases following BMV. Only 3 patients developed procedural complications of MR. Only 2 patients required emergency DVR. In the fast follow-up, the mean duration of 35 plus minus 23 months, the valve replacement surgery we could avoid in 86.6% patients. Only 5 patients required AVR. In second follow-up of 20 patients, 90.9% patients did not require any surgery. Only 2 patients underwent valve replacement surgery in the form of DVR. So this result supports our hypothesis of BMV followed by reassessment of symptoms in patients with severe MS, patients with associated significant aortic valve disease, instead of DVR as the first modality of treatment. To best of our true knowledge, this is the first study of BMV in the presence of associated significant aortic valve disease. The ACC guideline on valvular heart disease has no specific recommendation for BMV in cases of severe MS with associated AS, but in case of mixed AS with MR, they are telling if mitral anatomy is favorable, options are PTMC, that is PMBC, to treat the MS, followed by AVR or SAVR and open mitral commissurotomy. But in contrary, ESC guideline of valvular heart disease is saying that severe concomitant AV valve disease has contraindications for PTMC. But in our modest study, we have proven that safety and efficacy of BMV in this subset of patients. So Brunwald is saying that because DVR is associated with increased chances of short and long-term risk, BMV can be the first choice of procedure if MS is the predominant lesion, with subsequent AVR when needed. Still, this recommendation is not universally accepted and not included in all guidelines till date. Coming to the limitations, yes, the study was a small study with a very less number of population, only 49 patients we could include, and it was a retrospective observational study without any control group. And during the second follow-up in September 2020, quite a good number of study population lost follow-up. So, to conclude, BMV can be a safe and effective modality of treatment in patients with symptomatic severe mitral stenosis with associated significant aortic valve disease, and it can delay the need for valve replacement surgery and associated complications. Thank you.